non-pregnant patients with high blood pressure, there's been a lot of changes over the last decade or so where blood pressure used to be defined as 140/90, and that was kind of both the threshold and the treatment goal. There's now been a shift downward with a new definition of normal as 130/80. But our definitions in pregnancy have remained the same. So a new diagnosis of high blood pressure in pregnancy is still 140/90. And the question was, should we be rethinking that? Should we consider lowering that threshold, just like we have in the general population? Hi, my name is Andrea Katai. I'm a nephrologist and researcher at Mayo Clinic in Rochester. And I am here to talk to you and give you a summary of a recent paper that myself and colleagues have that's going to be coming out in the October issue of Mayo Clinic Proceedings, entitled Blood Pressure Thresholds for Hypertension in Pregnancy and Future Cardiovascular Risk. What we were really interested in is looking at different thresholds for diagnosing high blood pressure in pregnancy and what that meant for long-term cardiovascular risk for women. One thing that is a really important part of that, and part of the reason why the definition in the general population was changed, was what's long-term cardiovascular risk. That's why we treat high blood pressure, is to lower the risk of future cardiovascular events, future stroke, coronary artery disease, and death from cardiovascular causes. So we are uniquely positioned here at Mayo. We have the Rochester Epidemiology Project, which is a really powerful tool to look at medical records and different exposures in the population-based setting here in Olmsted County. And we have a cohort of women where we looked at those who had given birth in the 70s and 80s in Olmsted County, where we could look at their blood pressures and all their blood pressure readings, look at their risk factors when they came to age 45, and then look future at cardiovascular events. So kind of looking, if we had a woman at age 45, we looked back to see what happened in pregnancy, and we looked forward to see what's happening in terms of cardiovascular disease risk. And then we changed definitions of high blood pressure in pregnancy from 140/90 to 130/80 to see what that did to the incidence of hypertensive pregnancy disorders and what it did to the long-term cardiovascular risk. So our main findings were that by dropping that threshold for high blood pressure to 130/80 in pregnancy, there was a significant increase in the number of women who were classified as having hypertensive pregnancy disorders. We had a cohort of 1,700 women who had had a pregnancy and looked at their different blood pressures. And at a threshold of 140/90, so the standard definition that we use even at the current time, 15% of those women had at least one pregnancy that was complicated by hypertensive pregnancy disorders, including gestational hypertension and preeclampsia. If we then lowered that threshold to 130/80, that number went up to 44%. So it was a big jump, labeling almost half of the cohort of women as having had a hypertensive pregnancy disorder. Most of that increase was due to an increase in gestational hypertension diagnoses, as well as chronic hypertension. But the more severe phenotypes like preeclampsia, and particularly preterm preeclampsia, where people delivered before 37 weeks, there wasn't such a large increase. Then we said, okay, well, what happens to the future risk? And interestingly, we found at both thresholds, there was a significant association with future cardiovascular disease. That was true even we adjusted for different risk factors that these women had at age 45, like diabetes or high cholesterol or hypertension. So it didn't make a significant difference in terms of future risk prediction, but it did, using the lower threshold, dampen the degree of association. So whereas preterm preeclampsia, for example, was associated with a 2.6 times increased risk of cardiovascular disease in the future, including coronary artery disease and strokes, when we lowered the threshold to 130/80, it only was 2.2 times increased. So still significant, but didn't really refine what we already knew, which is that these women are at high cardiovascular risk. The other thing that we found was that women who were at age 45 who had hypertension in pregnancy by the higher threshold at 140/90, that was they were more likely to have hypertension at age 45, whereas the women who were at only met that definition by 130/80 and didn't meet that 140/90 threshold had a lower incidence of hypertension at age 45. So where does this leave us? Basically, this leaves us where we can say the kind of take-home message is that lowering the threshold from 140/90 to 130/80 dramatically increases the number of pregnancies that are complicated by hypertension, but it does not change the strength of the association between term or preterm preeclampsia with later cardiovascular disease, and that CVD risk, that cardiovascular risk, that signal persists across different thresholds. We did not feel that these results supported a lower threshold for a diagnosis in pregnancy to 130/80 based on long-term risk. There's still a lot of interest in whether short-term outcomes, so gestational age at delivery, birth weights, complications of delivery in the short term, whether those would benefit from a lower threshold is still an open question, and there's differing results in the literature. But that was not the question we were looking at. We were trying to add to the conversation, what is the long-term cardiovascular risk? And we don't see compelling evidence that change is going to impact patients in the long term. So where are we going from here? So we have a lot of interest in trying to expand these results. One is to look in a different population. Olmsted County, these pregnancies were in the 70s and 80s, so not the modern era. And also the population is predominantly white, and we know that Black women are much more likely to have hypertensive pregnancy disorders, and that might be a different conversation regarding a future cardiovascular risk. So that's still an open question. We're also working hard to make different electronic health record algorithms and look at different features besides just blood pressure thresholds. So things like different lab values, patterns, different biomarkers. Could those predict who's at risk for both short-term and long-term complications? And how can we really harness the power of the electronic health record and artificial intelligence to help us better care for women after a complicated pregnancy? So there's a lot of work still to do, but we hope that this data really adds to the conversation regarding how best to define high blood pressure in pregnancy and best care for our patients. We would love for you to read our paper in detail, look through our results, and I'd be very happy to communicate with anyone regarding them. This is still an open conversation, an open question, and we're excited to have future discourse.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.